For the next speaker, let's welcome Dr. Ingemar Davidson from United States, sharing about how does he practice 4 hours for American patients who need dialysis.
Everybody, I'm Ingemar Davidson from Dallas and the great state of Texas. I will divide my presentation in 3 parts. First, I will give you a perspective of how this phrase, doing the right thing, came about in the dialysis field. Second, I will share with you a snapshot from my own experience of applying this concept into my own professional life with dialysis access. Finally, I will conclude this concept of doing the right thing in an editorial type summary. In the beginning of my career, there was no dialysis and no kidney transplants available. Everybody with kidney failure or ESRD died, usually a very painful death of cerebral vascular nature from hypertensive complications associated with kidney failure. Fast forward to 2007, we published this review in Dialysis Access with a patient-centered approach to dialysis. One editorial advice to you who are younger in the audience than me is to include the powerful people around you, and when you publish, this is not only increasing your impact of your writing, but also protects you from much criticism. As you may be able to read, I included, with their consent of course, Dr. Maurizio Gallieni, who is still the editor of Journal of Vascular Access, and Dr. Dolmetsch, who runs the SIDA program with me. And finally, Dr. Saxena, who runs the peritoneal dialysis unit at Parkland Hospital in Dallas. In this article, Table 2, outlined on the left side in this image, seemed to catch much attention at the time. It is a mission statement for a dialysis access center designed to apply anywhere on the globe. The implications are that not any single access type or device can or must fit right for everybody, every time and everywhere. In fact, it varies depending on many factors. This is the core message of my talk. The concept of doing the right thing has stand the test of time. Forward from 2007 to 2012, Dr. Charmaine Locke of Toronto, Canada, and I wrote these follow-up papers reflecting the mission statement published now in Seminars in Nephrology. Dr. Locke, as everyone in this audience know, is the chairperson of the new 2019 KDOQI guidelines. And the new spirit of the DOQI guidelines concurs with the doing the right thing for everybody at all times. This is a slide from Dr. Locke's talk last year at the DASy meeting in Singapore, as well as the SIDA meeting in San Diego last October. I'm sure you have seen this image minutes ago during Dr. Locke's presentation of the new DOQI guidelines. In fact, the fistula first and the distal first concepts are no longer at the forefront of dialysis access DOQI guidelines. This message of one size fits all is no longer valid. Each patient needs individualized attention. I will in the next few slides explore the various situations out there using an altitude or metaphor. In this case is an operator who only performs AV fistulas for various reasons. From the aviation metaphor, he or she has not even left the airport. This scenario represents very limited options for the patient. To give you a global view of dialysis access, and let's elevate ourselves so that we can see the big picture of delivering dialysis access applied worldwide. In this scenario, at the bird's level, the access options now include catheters and grafts, but not peritoneal dialysis. There is a subliminal an unacceptable separation between PD and hemodialysis in many places in the world, which in fact deprives our patients from the most appropriate first-time dialysis mode in 50% of cases. A reason not to include PD is sometimes said as, I am a vascular surgeon, I don't do PD. The next level of access program includes peritoneal dialysis. This scenario is often associated with a transplant program. On the next altitude level, we can see the entire city where all access procedures are done in a coordinated fashion, including transplantation. If we decide to fly even higher at 60,000 feet at a supersonic speed, this image paraphrases the national level of ESRD and dialysis access planning. Again, now including disease prevention measures and transplantation. National planning and decision-making are in principle not different from local planning, only more so in terms of impact and consequences for many individuals. The DOCI guidelines is an example of the level of altitude metaphoric national planning. This image of the burning Concorde aircraft on takeoff from the Orly airport in Paris is a stark reminder that even the best and most sophisticated designed healthcare system can fail when human errors intercept and rules are not followed. Can we fly even higher? Yes, indeed we can. The International Space Station, abbreviated ISS, symbolizes the global approach to ESRD. As the ISS is an amazing technical achievement, there is ample evidence it has contributed to world peace by the requiring of trust and cooperation between the world's leading powers to achieve this mission in space. Clearly, the ESRD healthcare global community could do something similar, not even having to leave the airport. This is a somewhat heavy-loaded slide. It summarizes what modern, or perhaps better, an effective ESRD program could look like. This table outlines my thinking about the algorithmic selection of most optimal or the right renal replacement therapy. The subliminal message of this tabulation also is that ignoring transplantation, PD or grafts exclude up to 50% of your ESRD patients from the best or right renal replacement options. First, as medical professionals, our role is to prevent disease to happen in the first place. Obviously, we need an understanding patient or patient population, which is not a reality in most world societies. The patient responsibilities in prevention of kidney disease is a subject for another meeting session. After all, the kidney is the best dialysis machine. Few patients, or less than 3% in the US, qualify for a transplant per year for lack of acceptance criteria and lack of available organs. There are several compelling reasons to make peritoneal dialysis the most appropriate first-time dialysis modality in select patients, even in the case of excellent vascular mapping results. Patients who disqualify for PD should get an AV fistula when vascular mapping confirms suitable vascular anatomy. Then, in this algorithm, grafts come in with various strong benefits. For example, with the early cannulation grafts, central vein catheter contact time can be cut short or even eliminated. Grafts also are suitable in the elderly patients using the upper arm, where not only vessels are larger, but also associated with lower risk for steel or hand ischemia. You might even consider proximal arterial inflow, or PI, in the elderly and comorbid patients to avoid steel and the use of central venous catheters. Finally, many patients with ESRD are in the end stage of life when a central vein catheter is the right dialysis access, or perhaps even more often, no access is the right option for your fellow human being. This central algorithm follows what would be reasonable to consider when all options and support systems are in place. There are, of course, gray areas between these choices, including patient-specific wishes. One serious fact is, on a global scale, treatment with dialysis or a kidney transplant to stay alive may only be available to about 10% of the people who need this treatment to live. This table supports the use of grafts in the elderly, as longevity is limited. For example, a 75-year-old individual on dialysis has less than 3 years to live, compared to 10 years for the rest of us and 7 years for transplanted patients, a fact that should guide us in the selection or treatment options from a quality of life perspective. My second part of my presentation is to show that this approach works in real life. The next few slides summarizes one of the dialysis access activities at UT Dallas, Texas. Back in those days, the transplant surgeon did the dialysis access by default. No one else wanted to do it. So this year, 2012, is the statistics with no exclusions in 393 patients. You will notice at the top line, we placed PD catheters in 33% of the patients. This compares to 8% in the US as a whole. Of the rest, 67% who was having a hemodialysis access, 65% had a native vein AV fistula. Even a fistula first proponent would be proud of this statistics. In 35% of patients, we placed a graft. I must mention that we have a very active, dedicated transplant center with an excellent PD and hemodialysis clinic and nurse coordinators dedicated to the best possible patient care. Patient survival was excellent in the upper 98th percentile for PD, grafts, and fistulas. This picture depicts the intervention-free access survival for 12 months. As you can expect, based on the selection criteria, PD patients do better at 91%, followed by AV fistulas and grafts with 80 and 67% respectively. Here is the secondary patency or excess function at 1 year, again above 90% for PD. However, grafts and AV fistulas were now similar or overlapping because grafts are technically easier to declot than native veins. This is in part also due to our excellent service from interventional radiology on campus. One lesson we learned was not to follow dogma and public guidelines. From this graph, you can see that are placed too many radiocephalic AV fistulas, at least based on the outcome, with 65% function at 12 months, compared to 86 and 87% for upper arm basilic vein and brachiocephalic fistulas, respectively. We have since moved more proximal, following the suggestion I made in my algorithmic outline a few minutes ago. Here is another argument to rethink the dialysis access algorithm and fistula first concept. In this paper by Al-Balas, the overall cost of AV fistulas over grafts was about $4,000 or even more, or $10,000 in a single center study by Dr. DASy of Chicago, mainly by using early cannulation grafts and eliminating the use of central vein catheters. If the catheter use in the US would decrease from currently 80% at initiation to 20%, a society savings of $200 million would result. Similarly, if PD rate would increase from 8%, which is our current level in the US, to 30%, which is what we did in Dallas, a saving of $2 billion would be possible in the US. Along this thought, the prevalent PD rate in Hong Kong is 73%, suggesting that PD is indeed a viable option. PD as the first dialysis modality, which is not only the right thing to do, but it improves quality of life and it saves society much money. So how do we make everybody do the right thing? How do we have a dialysis access community that follows the patient-centered mission statement? Here are some challenging lists. The ESRD population is growing with increasing disease burden as well as in complexity. Patients are older and sicker. The treatment team usually consists of several medical specialties delivering dialysis access. We are transplant surgeons or vascular surgeons, interventionalists, each of us with different training background and expertise. So not surprisingly, we have different ideas about the best solution for the same patients. New ideas and technical innovations are coming quickly, and it is a challenge for the treatment team to learn how and when to use these new devices. The latest addition is the use of percutaneous endovascular placement of native AV fistulas. There are differences across the world in ESRD. For instance, a great variation in the incidence of disease, cultural ideas about renal replacement therapy, and what resources and technology are available. My editorial message is that the best answer is training and collaboration is the unifying force in the fragmented dialysis access world. To deeply understand these concepts, reading Steve Covey's book, The 7 Habits for Highly Effective People, will address and answer most of these philosophical questions. And I wish you the best for the DASy electronic meeting, and have a great day.